Just yesterday during a Reddit Ask Us Anything with some of our faculty experts, we received numerous questions about the pandemic, but there was definitely a large group of questions around this issue of mental health. A lot of people in that audience are looking for answers on how to cope through this pandemic. They're looking for an idea of when it's just going to be over and we can return to normal. And as many of us, no doubt, understand all too well, the effects of the coronavirus are not just physical but mental as well. The isolation, the loss of normalcy and connection, the fear of infection. For some people, it's access to care, or it's the economic toll of the pandemic that are weighing on us individually, but also as a community. We're seeing responses vary from community to community. Everyone's handling it in different ways and to different degrees. The existing vulnerable populations that are already stressed are being pushed to their limits even further now. And some experts are saying we should brace for a coming wave of behavioral health needs. There's statistics coming out for some of the national hotlines that are being that are receiving vast, like a wildly increased influx of calls, some upwards of 1,000% over what they experienced last year when things were relatively, well, normal back then. So here to talk about this issue, mental health in the pandemic, experts. We've got Louise Newton. She is a licensed clinical social worker and a certified somatic experiencing practitioner, AMD, and has been working in mental health treatment setting for 17 years. She's the clinical director of psychotherapy at MindPath Care Centers right here in the Triangle. And she is the clinical director of group practice at Catalyst Somatics and Psychotherapy in Durham. Along for the ride is Clara Kiley. She is the outreach coordinator. She's up in New York City. She's the outreach coordinator at the National Alliance on Mental Illness of New York City, or NAMI. Clara oversees outreach efforts and events in the community and coordinates programs and workshops, including the public education event lecture series and the In Our Own Voice presentation program. So you can learn more about her work by visiting NAMI-NYCmetro.org. And to pass the baton, let's start with Louise. Why don't you give us a quick intro into more detail on what you're doing?
Yes, thank you, everyone. Thank you for including me. So I'm a licensed clinical social worker. I have a small group of patients that I see. I've been working in mental health, the intersection of mental health, trauma, and addiction for 17 years. I also am the clinical director of psychotherapy for MindPath, which is formerly Carolina Partners in Mental Health Care. So we're statewide practice, and we provide outpatient psychotherapy, medication management, substance use treatment, various other modalities. One of my particular interests is working in trauma recovery, and as a certified somatic experiencing practitioner, I work a lot with nervous system responses, kind of what we all think of as fight, flight, freeze. There's a few more categories added since then, but I am working remotely. I've been working from my home for 2 months now. I also have a 4-year-old who just busted in my office, so that could happen. But most of my clinical work these days is really, and Clara, I'm sure you will relate, is really, the sessions are very focused on COVID-19, and we're just working on my kind of role clinically with my patients, and my role on a macro level as an administrator is trying to prevent post-traumatic stress as we endure this prolonged, this kind of unidentifiable threat out there. So working a lot with protective factors and undermining risk factors for developing post-traumatic stress, and then any sort of relapse in mental health or substance use treatment. So just that.
Thank you, Louise. Clara, what about you?
So yes, as you mentioned, I oversee a lot of sort of public outreach efforts that NAMI NYC is undergoing. We NAMI is obviously a national organization, but we serve New York City. Because of the switch to remote services, we are now seeing people. We're seeing people coming in from Westchester, from Long Island, from New Jersey, even from further afield, because nothing's stopping people. And we have really moved to offering a lot of just trying to create options for people support. We really focus on community and on lived experience and sharing lived experience. That's really what we focus on. And so, yeah, we just really have been trying to emphasize the importance of being able to talk with people who know what it's like, whether from the perspective of dealing with their own mental health issues or from the perspective of being a family member or a loved one. A lot of the services that we do are not just for people who are dealing with their own mental health issues, but are for people who are supporting somebody in their life who's struggling, because we know that, obviously there's a professional aspect to that. There's this idea of kind of vicarious trauma of kind of internalizing some of the stuff that if you're supporting somebody through something, you're going to get a little bit of the backlash. And I think, that's definitely true in just like a social and small context as well. So we try to sort of support people through that. So we definitely, we transitioned our helpline to be remote almost right away. And we've also been doing a lot of remote support groups via Zoom, via call-in options. We've been doing events like this for the public to kind of educate people about mental health related topics. We had one in April that was on insomnia, which was very well attended, as I'm sure. Yeah, Louise, I'm sure that you can imagine what kind of interest that elicited. So, and we have one coming up on Monday where two clinicians are going to be talking about mental health and COVID-19 as well. And again, naminyc.org, great place to learn more about that. But I'll kind of stop there, and
great.
If there's anything else I should elaborate on.
That was perfect. Thank you, Clara. And thank you both for the work you're doing to support this need. I look forward to dedicating a portion of this conversation to some of those opportunities that you talked about that wouldn't have been necessarily leaned on or even possible before the isolation began and before everything kind of went virtual. This, for instance, the increase in telehealth in reach that you mentioned, some of those opportunities are going to be long after the pandemic is over. That is going to be potentially a boon for this space and in many other spaces in health and medicine. So we'll talk about that a little bit more towards the end of the conversation. But first, I'd like to kind of set the landscape for what things look like right now. One thing, this is a question from multiple people from our audience and one that I had written down myself. I'd love to hear you guys talk a little bit about the unique characteristics of the pandemic. How is this different compared to other kind of long-term stressors, like some countries going through war, or you've got natural disasters where communities have to respond to a circumstance that's so far out of their control that it pushes us to our limits? And I'll leave it to either of you to chime in.
Okay, I can go. I think it's an excellent question. I think when we look at most other comparable contemporary traumatic events, such as war or natural disaster, there is a component of social connection that is a resiliency factor against developing post-traumatic stress. So, if you think about, Hurricane Katrina, the people who really suffered the most post-traumatic stress were people who had to leave New Orleans and never made their way back, right? Because there is this idea that, like, after the trauma, everyone comes together and rebuilds, and during a war, you know, the way soldiers are trained to kind of be together in their cohort, you know, and that camaraderie is one of the resiliency factors that helps them tolerate, so to speak, and sustain that extreme level of stress. I imagine what we'll see with some of the healthcare workers, that they'll have a similar set of experiences such as soldiers, because they really truly are in what we would consider front lines and are very having to work very tightly under extreme circumstances, more so obviously in New York City than in North Carolina. We've been a lot more fortunate. But the thing that that differentiates this is that we are not all bound together. That the way in which we can keep each other safe and best manage this is by literally not being together. So, you know, there is a real uniqueness in this prolonged threat. The only thing comparable that I've been thinking about is people who are in extended solitary confinement, for example, in prisons, you know, or probably prisoners of war, things like that. But we don't have any contemporary examples of this. And anything that's comparable has different resiliency aspects that we are creating through things like this, Zoom birthday parties, you know, people, you hear of teachers driving down the street to say hi to their students. You know, we are really truly trying to mimic as much of the social interaction as possible. But being pulled from that sort of social interaction, for some people, actually, it's quite comfortable. You know, people who are more anxious, social anxiety, social phobia, things like that. But for many of your folks, Clara, my guess is working at NAMI, there's a lot of what we call severe and persistent mental illness. That isolation piece is a huge risk factor. So with that, I can pass it over to you.
Yeah, definitely. I mean, yeah, I think everything that you said is really accurate. I think that isolation is really hard. I heard someone use a phrase that I think, sort of building off of that, I heard somebody use a phrase that I think really captures something that feels sort of unique about this situation, which was the phrase, we are all in the same storm, but we're not all in the same boat. And I think there's a sort of a thing, because this is, you know, everyone is being affected by this, right? Like, I don't think there's anyone who is not, whose life is exactly the same now as it was in January, you know, but people are being affected in very, and so there is this kind of collective, I think that's a potentially a positive thing, that there is this sense of collectivity and something that everyone is going through this together. But at the same time, I think the danger in that is that it can paper over the ways in which people's experiences are not the same and are very, very different. And people are being affected by this in different ways and to different degrees. And I think another piece is that people aren't getting to always, or in many cases, choose who they're very kind of closely bound up in this with. You know, we're seeing at least some kind of initial reports of increases in intimate partner violence, in family violence, where people are sort of, they're together and they're stuck together, and that's not a great thing. And I think, you know, we're also seeing, at least I think anecdotally, we're sort of seeing people kind of bonding with the people that they're sort of in their quarantine pod with. But you kind of, yeah, there is this limitation of sort of, you have your own experience, and it can be hard to sort of look outside of that.
Yeah, I think that's the thing that's been interesting for me to watch and experience myself, is just finding out which aspects of this are affecting me in ways that it doesn't necessarily affect my coworkers or even my wife and family who I live with. I'm curious. So I talked a little bit about the fact that our country is not exactly highly supportive, both from a federal standpoint and maybe even in kind of a social norm in supporting mental health in general. It's at the center of a lot of debates that stem from the problem. So we're in a stressed situation already, and this is stressing the system further. So one of the questions we got from our audience is, how is this worsening that already existing mental health crisis? Do you see it exacerbating some of these issues that we already knew about coming into this, and how might it change the situation after we come through this pandemic? Are there opportunities that this is bringing up that we're going to be able to address that might not have occurred March 11th?
Yeah. So I'll jump in and speak about that. I think in terms of worsening, and I'm sure this I think reflects some part of your experience as well. In terms of worsening existing mental health issues, we are definitely seeing. We don't have our organization doesn't have a ton of data yet about sort of concretely, numerically how this has affected people calling in or people attending groups, things like that. But anecdotally and from working on the helpline, I can say that we're definitely seeing a lot of people who are saying, I thought I had this issue under control. Things were going really smoothly, and now I'm falling back into these old patterns. Things are coming up for me that I thought I had dealt with long ago. And I'm kind of having to restart and redo some of that work, which in some cases that means if you've kind of already dealt with it, you have those coping mechanisms and you have those things to fall back on, which can be helpful. But definitely we're sort of seeing that, I think, on an individual level, this working of kind of pre-existing issues. And I think in general, it's really highlighting the way that all different kinds of healthcare are intertwined. Like, I don't think it's an exaggeration to say that we've kind of made a big mess of our healthcare system. And I think you can see that more generally with the coronavirus, where people are kind of en masse being unable to access healthcare because they've been laid off or they don't have access in other ways. And I think that you see that with the mental health care system. Like everyone that I know, even before this was happening, right? Everybody that I know or work with, including myself, who's tried to access mental health care, has some story about being denied care, being unable to sort of having their access to care interfered with in some kind of way, usually to the detriment of their mental health. And I think it sort of highlights the way in which we've really deprioritized preventative care. I think that mental health care, when it's really working correctly, is very much preventative care. You're trying to keep people from getting to that crisis point and from getting to a point where things are really exacerbated. And I think we're sort of seeing the results of that in the mental health care system and more broadly.
I think we only have to look at the trillions of dollars that Congress passed in emergency relief, and the tiny portion of that was allocated specifically for mental health is kind of supports your point right there. Louise, do you want to?
Yeah. So I do actually, as a member of our executive team, I have access to our numbers pretty much daily and our metrics. Our organization serves, as I said, the whole state. On a typical non-pandemic day, we may see hundreds of people a day across locations, and maybe something like, maybe up to, all right, so there was a day last week where we had almost the same exact number of telehealth sessions as we would on a normal day in office pre-pandemic, and that was something around 700 or 800 people. So what we had to do as an organization is literally overnight convert a huge practice into telehealth. We are fortunate that we've had a telehealth platform for several years, and our director of telehealth he's an MD, and he also has his MPH from UNC where he studied telehealth. So, you know, and we already had it all worked out with the insurance companies. I mean, we're very, very fortunate as an organization that we were literally I literally brought my plants home one day, figured out, hired a nanny and just started working from home, and the transition was pretty smooth. We saw a major dip in initial intakes, and that's a first point of contact, and that is slowly creeping up. We anticipate actually be kind of flush, so to speak. So we're still hiring, you know, which is not true for many industries. From a financial standpoint, our other medical practices of our size, of different kinds of medical practice, have lost anywhere between 50 to 75% of revenue, meaning that's how few people are coming in, because in the medical industry, all of your revenue comes from patient contacts, right? And people aren't like, I don't want to go to the doctor's office. You know, I'd much rather use a telehealth or nurse my little cold or whatever I might have back to health myself. So we've only seen a 25% dip during these last 2 months. So we feel like fiscally and kind of professionally, we feel fortunate. But I will say that I feel a little bit positive in North Carolina that there is a little bit more of an explicit conversation through the North Carolina Department of Health and Human Services. Just yesterday, Mayor Steve Schul, who's the mayor of my city of Durham, made a shout out to Alliance, which is a huge organization that serves the community mental health. So I'm hopeful that as we think of people as like the worried well, and I'm talking in hierarchy specifically on purpose. So when we think of people who are higher functioning, important people in our society who are starting to have stress, anxiety, and seeking care for that could bring up that could kind of normalize the need for mental health care for others. I think that's a little optimistic, honestly. I don't know, Clara, you're working more, I did 10 years of working kind of in similar populations that you work with before I joined the private practice realm. I imagine overall the people who are experiencing the intersections of mental health, stability, income instability, food insecurity, physical diabetes, some of these other factors are really, really going to just be the hardest hit. Well, they already happened. We know this. This data has happened. But for your average middle class white person with a graduate degree, which is myself, we are seeing kind of a surge in people seeking care. So it'll be which way that goes.
I think that's a great segue into another topic that many of our questions kind of hovered around, and that's and Clara, you just started to touch on this when you mentioned some of the specific vulnerable communities, but I think of those with substance abuse, those who are in poverty or extreme poverty. Perhaps you can go, and I would also love to hear from you, Clara, how you felt your community, New York City, has been supported. I think, as Louise said, North Carolina is fortunate. We just had a wonderful conversation with the Vice President of Communications at Duke and our Mayor Pro Tem in Durham, and a lot of the feedback kind of mirrored saying, Louise, there's been some good collaboration here. So sorry for the two-parter there, Clara, but I'll turn it to you. One, I'd love to go deeper into kind of the vulnerable population aspect of the conversation, but before we do that, maybe you can talk about the wins and losses you've seen in New York City as far as collaboration.
Sure. So, I mean, New York City has really been very badly hit. I think that is just sort of numerically the case. In terms of wins and losses, I mean, I think it's hard for me to say, so I don't want to make things up. But I think we are starting to sort of see, I think we've really been completely shut down for many weeks, and we are starting to see, a little bit of things leveling off. But, especially our healthcare providers have been really badly hit with the virus, with sort of additional trauma and stress. And I think in order to come out of, I think it's really important to emphasize that in order to kind of grow from this and come out of this, we really have to make sure that we're listening to the folks that have been most hard hit. There's some studies that have come out of the CDC showing that nationwide, African Americans and other people of color have really been disproportionately struck by illness and death because of this. I think it's really important to listen to the doctors and nurses and the other healthcare workers that are saying, look, I don't want you to call me a hero. I want you to give me some PPE. And I think, I don't know more specifically the kind of how well we've done at kind of listening to those voices, but I think that's really necessary. And I guess one more thing that I'll say about kind of most vulnerable populations. Sorry, I feel like I'm going around the question.
That's my fault for asking too many questions at once.
But in terms of vulnerable populations, something that I've definitely seen in our support groups, particularly for folks who really rely on our organization for community and for interaction and just to kind of be in a social space. I think the importance of kind of, like I said before, I think people don't always have access to their sort of chosen, the people that they most feel connected to and want to interact with. And so having a space where people can really talk and interact with people who have a similar experience of what's happening as they do is important. I don't know if hopefully that's clear.
Luis, just give me a second if you want to contribute anything. I have a follow-on, but.
Oh, you can, she did a great job.
So that is another question that's come in is what will our new normal look like afterwards? What are the way that healthcare is adapting to this? We talked about telehealth earlier. You just started to mention one of the problems is a support system that was in place has kind of been swept out from underneath the people that need it. And there have been some adaptations there. What have been some of the barriers that have prevented kind of psychotherapy or just mental therapy in general from transitioning to a virtual space? Whether it's a regulation or just a feasibility problem.
I can start off that one. A lot of the telehealth experts are calling this the tipping point. That this is transforming all healthcare systems, and I think in some ways that's really exciting. For folks, like, for example, one of the populations that I work with is working with transgender folks, and in North Carolina, you still have to get a full mental health evaluation to access basic medical care as a trans person. And so I've had patients drive 4 hours for an appointment, right? So as we think about that, we think about there are some beautiful things that are going to come out of this, right? So people who are in the disability rights community are making a really great case that you can work from home, that this idea that you have to be able-bodied in an office 8 to 5, that's all changing. That's all changing. And as capitalism goes, it's going to realize like, oh, actually, it's maybe cheaper to have some people working from home instead of paying rent on this huge office building we have. So I think that there are some positives that are going to come out of this as far as being able to, like people in rural communities, being able to access mental health care. You know, my patients can do their session on their phone. If they have a smartphone or a tablet or a computer, they just literally just push a few buttons, and that's how we have our session. The downside of this, I would say, as a practitioner, is it is much harder for me to get in residence with my patients, and in residence meaning like in that kind of empathic give and take where I'm really sensing what's happening with them and they're sensing my presence. I'm fortunate that most of the caseload I've been seeing anywhere from 5 to 7 years, and we're kind of under this illusion that this is for now, and we're kind of putting like Band-Aids on and patching things up. With regards to what the new normal is going to be, you know, I have some very optimistic hopes and I have some very dark fears. You know, I honestly have literally thought like, wow, what's going to happen when everyone's out at the first concert at an arena? Is there going to be a mass shooter? Like some festering sociopath is just kind of sitting around and waiting, you know? And again, I'm not trying to be morbid here, but I think there's going to be a lot, I think, with fear comes anger and a lot of ways in which people respond to their own fear. They either override it and protest the governor and get COVID-19 themselves, which has happened here in North Carolina, or they can get angry at others, you know, in the grocery store. I mean, I think there's just going to be these strange, and every area is going to be different. New York City is going to be absolutely different than even the biggest cities in North Carolina, you know, both kind of structurally and culturally. I believe there's going to be some really beautiful things that come out of this, and there already have, and there's going to be some long-lasting effects that we can't anticipate. And all we have is Wuhan and Italy a few months ahead of us to draw the research from. So with that, I'll pass it.
Yeah, I mean, I definitely, we've already started to have conversations. And I think there were a lot of barriers, especially administrative barriers to, I feel like, Louise, you probably know more. We don't do a lot of things through like reimbursement or anything through Medicaid and Medicare. So I'm not as familiar with the sort of barriers that existed for telehealth, mental health care through that. Although I believe that there were a number of barriers, but we definitely have already started to have conversations about how can we incorporate this kind of distanced remote mental health services into our work, even once in-person gatherings are useful, because it's are possible, because it is really useful. It's there are people that are able to access remote support groups and remote care that were not able to access it when it was in person. And we definitely want to make sure that those people keep being able to access that kind of support that they may have found. And then at the same time, we definitely run into a lot of barriers. And in some ways, it's kind of exacerbated existing disparities in terms of access, where it's like, not everyone has reliable internet. Not everyone has a computer with a camera in it. Not everyone has privacy. That's a big issue that we've run into in terms of our groups and even our group facilitators. Like, there were some facilitators for our support groups that said, look, we can't facilitate this group because we don't have a private space. That's not fair to the participants, you know, who are expecting confidentiality. So that those are all, I think, significant barriers.
Yeah, I would add to that, Clara, and I'm sure you all are talking about this as well, structurally, as an organization, we are like in real time trying to read the playbook so that next time we have another wave, that we can just simply go like, hey, here's what we do now, right? This is what we've learned, this is what worked, this is what didn't work, and we're also trying to do some internal research to contribute to the body of knowledge. But that's a whole, like I was joking for the first month that I had a whole second job on top of everything, which was figuring out how to manage 85 therapists and all of their patients. And advocate, because the social worker is going to be the one who's saying, hey, what about this, in a way like MPH students would, which can be very different from your clinical psychologist, or we're trained in crisis work, right? So and looking at public health, so it's been very fascinating. As an organization, I'm proud of what we're doing, but we are prepared for these kind of in and out, and some people in our organization, whether they're staff or providers, and some of our patients may never really get out for a while, right? So we're preparing for that as well.
One of our audience members asks, what tools are being made available right now to kind of address the people that need the help right now? And we've talked kind of about what I think could be characterized as like traditional telehealth. That's like a face-to-face video call like this, or a telephone call for screening purposes and whatnot. But I've always been fascinated over the past couple of years by some of the technology that's come out that might actually help serve some of the points that you brought up, Clara, like the privacy issue. So I don't know if either of you are familiar with either of these examples, but there's an app called Wobot. And Wobot, it's basically which university put it together, but a group of researchers built this app that is it's basically, I think it's assisted by artificial intelligence, and you're able to interact with it. And what it does, it has kind of a multiplying effect on an already understaffed field. So I think that's another problem that we haven't really talked about, and that's just the amount of social workers that are not available to address this crisis, or the ability for trained professionals to meet the demand. If all things were perfect, that the demand still outweighs the ability to support before the pandemic, if I remember correctly. So all that being said, what other kind of interesting technologies have you guys come across, like Wobot, or I think there was another website called Talkspace, where people it's the evolution of a hotline.
Right. Well, I will tell you, Ben, can I just tell you, you're going to most therapists, when you start talking about AI and Talkspace, are going to be like, stop it, that's dystopian, this is not how we're trained, we're relational people, la, 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 la.
Yeah, and you mentioned that.
That being said, we are undergoing an AI study right now in our clinical trials department. So we're contracted with an AI organization that wants to track intonation of voice of patients and suicide, depression inventory. I don't know how many therapists we're going to actually involve, or patients. There's some people who are like, yes, I'd love to contribute to the body of knowledge, but that stuff isn't really, we're not there yet. And a lot of us honestly don't want to go there. This is pushing us there in a way. Our associate clinical director was like, I am not going to do telehealth. And her husband was like, yes, you are.
Yeah.
Because her mother lives with them, and her mother has COPD, and she's like so techno avoidant, and she's having to really adjust, and she's an excellent clinician. But I think in our field, it's so nuanced that this conversation of AI with diagnoses and things like that is so much more different than plugging in a few symptoms of like, I think I have a sinus infection, and a robot spits out a kind of like, this is about approximately what could be going on,
I think the best description I saw of it was was a mix, and not a one replacement. And to your point, like and to the point about isolation and having a virtual meeting like this, there's just no substitute for being face-to-face, for the contact, the physical contact and the proximity that's part of being human. I don't think that's ever going to go away entirely. So I'm curious, when I think of going back to WOBA as an example, behind that is a team of practicing therapists who are engaging their patients still. And what they're looking for is a way to enhance their in-person efforts, where maybe they're meeting 1 to 3 times a week in person. And then in between, you might fill a need that helps a person struggling to train their resilience and their cognitive therapy training and things along those lines. So you have this tool that they can then rely on in between their sessions with a trained person in real time, face to face.
Well, that's where Clara's organization is huge. I mean, NAMI in North Carolina is the in-between, like 12-step is the in-between, I don't know what's going to happen with AI. I will keep you posted, because I got an email yesterday I'm supposed to follow up with around seeing who wants to participate in this AI study for my department. I think we are going to get more comfortable with all of this technology as a result of this. So we'll see. That's an interesting question. Clara, I don't know if you want to say anything more about that.
I mean, I think, yes, I think there are things like, for example, chatting via text.
Yeah, I do that with my patients.
For folks that may not have a camera or, might not have, I think there's ways to use technology to sort of supplement what, to kind of fill those gaps. And I think that a lot of people, everyone is sort of trying out things and kind of trying to figure out what works and what doesn't work. And I think it's very much a process of trial and error. And I think we're gonna continue to see that. But I think, there's really no replacement for, I'm also a social worker, not the clinical one, but a social worker. And, the baseline of the therapeutic relationship is that it's a warm, non-judgmental presence. And that, I think, is very hard to replace. That requires a person.
My clients have been bemoaning not having the drive from wherever they were to therapy, because that's a time every week, every other week, where they're like, okay, what am I going to tell Louise? And, right, this really cool thing happened, and I need to kind of get my thoughts in order. However, I have clients who say they love not having to wait in a waiting room.
Right.
Although I will say, my waiting room is kind of fabulous. We've got really nice art, and it's not your typical clinical kind of institutional situation, but still, I think there's interesting. It's just really interesting because we're not traveling from here to there. There's not this time that we're used to between. Even just going to the bathroom for me between sessions, I get to engage with my 4.5-year-old, which means I have to stop my sessions a few minutes earlier than I normally do, because I can't just whip right out of my office and back in like I can at my work, So there's a lot of changes. So, it's really interesting.
So now that we don't have that commute in those inactive time, you're forced to stop life on your commute to your next space. What are some of the tips and tricks you're telling your patients or telling the folks that you're working with to help cope day to day with this? Like I've read, step away from the news for a while, limit that intake. What are some other things that are takeaways for someone who's struggling with the weight of this pandemic that could help them find that moment of peace, if only momentary?
Well, I encourage my colleagues and my patients, if showers are something they enjoy and that's a part of their morning routine, to treat their shower like their commute, to kind of just take a few extra minutes in the shower. That's not everybody enjoys a shower, but if it is a resource for you, then that's the time where you can kind of gather your thoughts, hopefully have a little bit more peace and quiet. It's kind of an understood rule in most safe, healthy households that if someone's in the shower, that you just don't even go in there, you know. Of course, limiting news intake, and I as a trauma therapist, I strongly encouraging limiting media consumption with visuals, because what we learned after 9/11 was that visual, that over and over visual, was really harmful with regards to children whose parents had their TV on, but also there's a desire to look and there's a desire to look away and look and to look away, because it's this, I need to know what's happening and I'm horrified at the same time. And when our nervous system is pushing the gas and the brakes, which we're all dealing with right now, that's where we start moving out of our zone of tolerance and into overwhelm. So, you know, I said, what's the word? Masochistically was watching some of the daily White House briefings, and I think at the beginning, because I was like looking for information and realized that it literally was, for me, was making me feel very dysregulated, because the information and the strategies are designed to be disorienting to people's systems. And when the information and strategies coming from the larger people who are supposed to be kind of keeping us safe and protected are intentionally disorienting our system, then that's not going to increase my resiliency. It's not going to increase my mental health. My mental health will not be optimum after some sort of information that's hard to understand or is actually being put out there to kind of see what happens, right? So I encourage people to choose what kind of news media outlet is safest for them. So what I talk about is orienting to the threat, orienting to the information. Okay, here are the numbers. If you're a numbers person, Dr. Cohen in North Carolina is doing a freaking great job with her data, or the websites that are tracking this. Orient to the numbers, orient to the stories, hospital workers, orient to what people are doing, and then orient to the helpers. So who is here to help? Because if you just stay focused on the threat, then your system will go into overwhelm. If you can toggle between the threat and the helping, then you're pendulating your system in such a way that you're going to be able to stay within a certain reasonable window of tolerance. And then the last piece I talk about, which is very hard right now, is to get in community. And this is an example of that, right? To share time with colleagues. One thing we're doing at MindPath is every day from 12 to 1, my associate director and I we hold a standing meeting in different cohorts. So we do the call center, the clinicians, the executive team, the front desk folks. It's called Caring for Ourselves While We Care for Others. And it's where people can talk about, oh my gosh, I'm getting all these calls and I'm hearing this and I'm hearing that. We're trying to prevent post-traumatic stress on a macro level, right? So, you know, I think that anyone can give you a list of things like eat really good food and drink lots of water and get your good sleep and get up and stretch and walk outside every day. That's really freaking hard right now. So if anyone's doing at least 3 of those things, hats off to you. Give yourself a big pat on the back. And also, not everybody has access to that. So with that, I'll pass it on to you, Clara, because I feel like I went off on a little bit of a diatribe.
It's easy to do. I mean, I think, and I think you said this, but I'm just going to sort of emphasize it because I really think it's the number one important thing, focusing on feelings of agency and what you can control. Because the feelings of helplessness and numbness are the most difficult to deal with and are sort of signals of that feeling of overwhelm. And I know even from my own experience, focusing on what I can concretely do and things that make me feel like I have some agency are really crucial to fighting those feelings. And that could be so many things, you know, it's calling if it's writing or photography or cooking, cleaning your apartment or coloring or working at, like, you could go on and on. And different things are going to speak to different people. And I think that's really important as well. Just finding ways to feel active and feel that sense of agency and control. And I think, you know, sort of trying to go into feelings of curiosity and kind of what's the phrase, like just focusing on being curious and aware of what works for you and what what you need. And I think kind of what you talked about with, you know, your patients who are like, oh, I really miss that feeling of having the drive to my appointment in order to kind of get my thoughts together. Just noticing stuff like that and saying, okay, how can maybe there's another way that I can get that feeling. And I think people are really instinctively doing that. You know, I think people are sort of instinctively falling back on those creative and just and those things that make them feel kind of a little bit in control of at least their own environment. And so I think just following those instincts and being aware of how something is making you feel and being curious about, you know, oh, like how am I doing with this? What could I do differently? It's important. And I think it's also important to distinguish this sort of like feeling of activity that I'm talking about from the kind of compulsive productivity that I think that it's very easy to fall into, because that can be its own kind of trap. And I think a lot of the difference has to do with intentionality. Like there's a difference between just doing whatever's in front of you just to feel like you're doing something and choosing to do something intentionally because you want to make a difference in your own situation, want to make a difference in somebody else's situation.
Is the example like just compulsively cleaning your house because it focuses your mind on something but doesn't actually address the underlying emotion that's occurring there?
Right. And I think that's where self-awareness is really important, because one person's like, you know, I clean my whole apartment and now my apartment is like spotless and it makes me feel like I have control over my environment, is, you know, can look externally just the same as somebody who is like, I can't stop cleaning even though it's making me feel really neurotic and terrible, but like it's the only thing that I can focus on, and so that's what I'm doing because like that's what, you know, it can look the same on the outside. And so I think that self-awareness and just kind of awareness and curiosity about like, how is this making me feel, what feelings is this bringing up for me is really crucial.
Yeah, that reminds me of, I was reading something about the stages of grief, and there was a recent article that came out explaining how that feeling that everyone is feeling is part of that is grief, where we're grieving right now. And the article explored various, the various stages of grief and specifically focused around the acceptance and mentioned, I think, that getting to the point of acceptance is part of figuring out how to get that sense of control and agency back. Would you say that's accurate?
Well, so what I would say about that is that I think agency is very different. I know I use the word control, but I appreciate you bringing up the example of grief because I think it highlights something that is also important to talk about, which is there's a difference between agency and control. I think that somebody who's trying to control every aspect of the situation or their own reactions to the situation, I think that can also become very stressful and painful because we can't control a lot of what's going on. There are a lot of things that we do not have control over, and that's one of the things that I think is like brings up those feelings of grief for people and is part of grieving, is saying that, you know, there's a lot of really bad things that are happening that we can't stop. And sitting with that and kind of being able to sit with that and kind of feel that becoming overwhelmed is I think a crucial part of this process. And people, you know, I think I read that article that you mentioned as well, and I think it talks about how people are really uncomfortable with grief. You know, it's one of those things that just makes people very uncomfortable because it's something that can be fixed or solved or got taken
or even
away.
anticipated.
It's just something that, or anticipated or controlled. Right? It's just really important to be able, and especially able to, you know, hear somebody saying like, I'm not okay.
Right.
And to, I'm really sorry and thank you for telling me, and not try to fix it and not try to solve it.
I think it was in that same article that, and I saved the note because it resonated with me, the idea that emotions need motion, that you have to recognize that. We are just starting to go over our time. This discussion has been awesome. Thank you so much for your time today, for sharing your expertise and your insight in this area. We're gonna post some of the articles that I brought up and the one that Clara and I were just referencing to the event on our website if anyone's curious and wants to read about this. And for Luis and Clara, if there's anything you think would be valuable, or you do come across something like here are the tips, or here are the tools that are being used right now for those people suffering under the weight of the things that we've discussed today, we would love to post them to that event as well and make them available. And obviously, I'd encourage everyone to go check out your work. Like I said, Luis is right here in the Triangle, and if we have guests from New York City, Clara's in your backyard as well. Any last comments? Closing remarks from either?
I just wanted to follow up with what Clara was saying. You know, I think we're all suffering, and the thing that I'm working with personally, and the thing I'm working with my clients, which is very much a grief skill, is really riding the waves. So when I have a crappy day, it's just a crappy day. And historically in psychology, we talk about changing unhelpful thoughts and improving mental health. And those kind of typical CBT tricks are helpful with reducing the kind of extreme places we can go. But some of this we can't change. And that's the big lesson in grief, is that, you know, when you have your good days and be like, whew, that was a good day. You know, if you're feeling scared, that's okay. This is scary. We are literally trying to survive a pandemic. And I'm not being dramatic. You know, I'm actually being honest. So I work with myself, I work with my 4.5-year-old, and I work with my patients and the colleagues that I supervise around, really, to the extent that you can tolerate, going in and out and not setting up shop in despair and not setting up shop in fear or denial, but noticing, as Clara was talking, and tracking the evolution of those feelings and sensations throughout the day, really throughout the day. So, and we're all resilient. Humans are designed to be resilient. So just thank our exquisite evolution for designing us towards resiliency in more cases than not.
Thank you, Louise. Claire, we've seen you come in and out a little bit. I can't tell if your connection's still there.
Am I should, hopefully I'm still there.
We see, yep, we hear you.
Okay, great. I think I've I said my piece, and I think Louise, you sort of pulled it together really well. But yeah, I think, you know, being very kind to ourselves and accepting of ourselves is it's hard. It's really hard, but it's always important, and now it continues to be important.
Yes. Thank you again, both of you. And a reminder to our audience, we'll be here next week as well for another coronavirus conversation where we're going to be exploring immigration in the pandemic. We'll see you next time.
Thank you so much.